everyone, and welcome to today's webinar, Interventional Treatment for PE, Tips and Techniques. I would now like to introduce Eileen Sue, EKOS Senior Marketing Manager, who will be introducing today's speaker.
Thank you, Kat, and thank you everyone for joining us. I'm pleased to introduce today's speaker, Dr. Keith Sterling, the Director of Cardiovascular and Interventional Radiology and Director of Research at Inova Alexandria Hospital in Virginia, where he has been in clinical practice since 1995. He is also an Associate Professor of Radiology at George Washington University and has been a noted faculty member at several national and international medical conferences and society meetings. Dr. Sterling specializes in minimally invasive techniques in vascular and interventional radiology and is a noted expert in the treatment of PE. During today's presentation, he will be sharing specific tips and techniques he has learned for treating PE in what is sure to be an engaging, case-based discussion. With that, I'd like to turn this over to Dr. Sterling.
Thank you, Eileen. Just as a matter of introduction, so this is going to primarily be a case-based webinar where I'm going to show cases that have kind of highlighted our education in our practice of treating acute massive and submassive PE over the last 6+ years. So before we get started, we do have a couple poll questions, and these are my disclosures first. And so here's the first poll question, which is just to kind of get an idea of our audience. And so we did add another specialty here, so just people who are on, you can answer, and when we get a critical number of people, we'll show everybody the results. Great. Okay, so and here's our results. So we did this webinar a little earlier this evening for primarily an East Coast audience, where it's interesting. We had a very it was very cardiology heavy in terms of our the people who were participating. So it seems we have a pretty even distribution of vascular specialties here, and I'm still not sure what other is, but perhaps maybe emergency room or such. So okay, and our next question: how would you characterize your experience at treating PE? And here is that poll. Okay, so again, we have a pretty, share the results. Okay, so again, it seems like we have a pretty broad distribution of experience. So I think we'll touch on a variety of topics that really suit everybody's needs, on both basic and potentially more advanced, and whatever we don't get to, we can certainly cover in the Q&A section. So let me get started. All right, so when it comes to treating PE with catheter-based therapy, a lot of the goals of this catheter-based therapy are really the exact same that have been pointed out before in treating PE with systemic thrombolysis, which is to recover right ventricular dysfunction, decrease pulmonary vascular resistance and pulmonary pressure, increase systemic arterial pressure, such as with the massive PE patients, improve symptoms and survival, first and foremost, and decrease the risk of potentially developing CTEPH, or chronic thromboembolic pulmonary hypertension. And when we're talking about which patients to treat, this is taken from the AHI guidelines, and we're really talking again about massive PE and submassive PE. And just because we do have some people who are new into treating PE, patients with massive PE probably represent 5% or so of patients who present with acute PE, and those are patients who have sustained hypotension with a blood pressure of less than 90 millimeters of mercury for at least 15 minutes, those who are on pressors or really in cardiogenic shock. Minor or low-risk PE, that's not what we're talking about treating with catheter-based therapy. And then submassive, which is a group that I think people are identifying with even more and more frequency as more imaging is being done. And those are patients who have evidence of either right ventricular dysfunction on imaging, such as echo or CT angiogram, or have evidence of myocardial ischemia with increased troponin or myocardial stretch with an elevated BMP. But those patients are hemodynamically stable. Now, when we're deciding who to treat, we can take those categories of massive and submassive and further subdivide them. So when we look at treating massive patients, there's the patients who are absolutely crashing, they're in shock, they're ready to die in front of you. And then the patients who are massive, but they're not crashing. They're obviously very sick, they're hypotensive, but they're what we call a stable massive. And then submassive PE patients are those who are really just teetering on massive, that by all the AHA criteria, they're in the submassive or intermediate risk group, but they're normotensive. Or they have significant RV dysfunction, and they're not necessarily teetering. They may be totally normotensive, but they have a significant amount of RV dysfunction. And then there's the patients who are bordering on low risk, such as those who are completely stable, might have a slightly elevated RV to LV ratio with RV dysfunction, but it might be, if normal is under 0.7 as a ratio, they may be around 0.9. And I think it's important to subcategorize these patients. Now, we do use other things to try and further identify who may and may not be a candidate for which type of treatment. And we have employed, and I'll show you in a second, the simplified PESI score, as because that contains, and you'll see in a second, different criteria which may tell you that that submassive patient might be at increased risk for mortality. And those are criteria that wouldn't necessarily change their AHA criteria of massive versus submassive, but they may help to identify patients who may be on the sicker end of a submassive category. We do look at biomarkers. There are studies that have shown when both biomarkers are elevated along with RV dysfunction, they have a higher incidence of clinical deterioration or requirement of escalation of therapy. We're going to look at patients' bleeding risks. You're going to look at the skills that are available by the physicians in your hospital, as well as the equipment available at your hospital. So this is the PESI score. So on the left, you have the original PESI score, which is a pretty convoluted and scoring system. And the right is the SPESI, or simplified PESI score. And if you'll see, you may have a patient who's a submassive PE, but if they have a heart rate that's over 110 a minute, they get 1 point. And as I said earlier, 1 point or more on a simplified PESI score is associated with a 30-day mortality risk of 11%. So these are things we look at when we're looking at our submassive patients to sometimes drive decisions to treat patients versus not treat patients, or at least identify those patients who we're a little more worried about prior to making decisions. So our typical call, as I'm sure a lot of yours, this is a typical patient that we see. And here's a 46-year-old male presented to the ED with chest pain and shortness of breath. You know, most of these patients are going to come in through your EDs. Blood pressure 116/72, so normotensive, heart rate of 98 a minute. O2 sat, though, on room air was 92%, so definitely trending towards mildly hypoxic. The patient did have a troponin leak of 0.32, and so by criteria, this would be somebody who has a submassive pulmonary embolism by clinical criteria. And you'll see down here they had RV dysfunction. However, we do look at something, the lactic acid. So this patient may at one point been significantly hypotensive. So this is going to tell you that this patient might be on the sicker order of submassives. The patient had a saddle and bilateral pulmonary embolism, and as I said earlier, and you'll see in a second, had an RV-LV ratio of 1.7. And so this is the imaging and a couple slices through the patient's CT angiogram. You'll see the saddle pulmonary embolism and then obstructive pulmonary thrombus really into both the right and left pulmonary arteries. And here you have the four-chambered view, which is easily seen on a CT scan. Here's your RV and here's your LV, and you can see that that's your ratio of 1.7. And really, you don't need to calipers for this to know that this is significantly increased RV diameter compared with the LV. So our go-to for treatment for these patients has been the EKOS system. And for those of you who may not be as familiar with the EKOS system, what it is a multi-side hole infusion catheter, which is on the top of this right-hand picture. And this is just a multi-side hole catheter where thrombolytic drug will drip in out of the holes. Over here is a close-up of the catheter. So this catheter is highly engineered, and it has a few different ports in it. It has one port where you're going to deliver the drug or the TPA. It has another port for coolant, which is normal saline, usually going in at about 30 to 35 milliliters an hour. And in the center is where this ultrasound core, and this is really the main engineering of this device, where you have these ultrasound elements which are spaced evenly distributed at 1 centimeter increments, and they're going to generate ultrasound energy along the course of the catheter. And you see the catheter comes in lengths between 6 centimeter treatment zone and 50 centimeter treatment zones. For PE, we're primarily using the 12, most commonly and occasionally the 18 centimeter infusion length catheters. So this is going to go in the central lumen of the catheter once you put your wire out. And the whole idea is this is not a mechanical device. It doesn't disrupt the clot. What it does is the ultrasound energy will cause the fibrin strands to separate and allow a much more effective and efficient distribution of the TPA into the clot.